hello everyone, welcome to Hamilton Symposium Medical Robotics, and today we are meeting here for the workshop on computer vision and augmented reality in surgery. I would ask Duygu Sarikaya, who is co-organizing workshop together with me, to formally introduce the workshop and introduce our first keynote speaker. Duygu, back to you.
Hello, everyone. Like Sharif said, welcome to the final workshop at the Hamilton Symposium on Medical Robotics. That's the computer vision and augmented reality in surgery. As you know, other recent advances in machine learning and computer vision and augmented reality has been long a part of the medical domain, but we don't see those advances yet being translated into the surgical domain. And we have some unique challenges. And for example, unstructured environment is one of them, because every patient has a different anatomy. And today we will see how we can use computer vision and augmented reality to help surgeons navigate these complex procedures. So I want to thank you all for joining. And we will have 3 speakers and a panel discussion. And you can always ask your questions at the chat box, or you can raise your hand so we can give you the turn to ask your questions at the end of each talk. By the way, I see Matthias here, and he's our first speaker. I will let Sharif introduce our first speaker. Thank you again. And also thank you to Marianne Knight. She's been a superhero for us and helped us put together this workshop.
Thanks, Duygu, for the introduction. So I think it's my pleasure to invite Matthias Unberat, who is an assistant professor in the Department of Computer Science at Johns Hopkins University and affiliated with the Laboratory for Computational Sensing and Robotics and the Malone Center for Engineering and Healthcare. So Matthias completed his PhD in computer science at the Friedrich Alexander Universität Erlangen in 2017. And Matthias is recipient of several awards, grants, and fellowships. His group is called Arcade Lab, and where he and his colleagues developed several collaborative intelligence systems that support clinical workflows to increase the access to and expand the possibilities of highest possible healthcare. That's quite interesting. So today's title of Matthias' talk will be on 3D vision in endoscopy. Let's hear more from Matthias. So Matthias, welcome.
Thank you very much. I hope that my technical difficulties are resolved and you can see my slides.
Yes, we can see it.
Wonderful. Beautiful. So today I decided I should talk a little bit about the recent advances in 3D vision and endoscopy. And I decided to talk about stereo depth estimation, particularly because the time allocation for the individual talks is a little bit short, and focusing on too much I thought would probably not be useful. So let me start by acknowledging the great people that contribute to the work that I will be presenting. So this here is my group, and at the bottom you can see some of the collaborators. I think, of course, our students are wonderful, but what is even more wonderful here at Hopkins, and I hope at your institutions as well, are the clinical collaborators that take time out of their busy schedules to come meet with us and you know, brainstorm the most important solutions for the problems that they are facing every day in their routine. And here, this is Masaru Ishii and Pete Creighton, who are both surgeons at Hopkins working with us on developing these solutions. So why should we care about 3D vision in endoscopy? So one of the challenges that I think we probably all know is that an endoscope is essentially a projective camera. What it takes is 2D images of a 3-dimensional scene. So what happens is in the image formation process, we encounter this projective mapping of the three-dimensional scene.
Sorry to interrupt you. There's a question. So we can see it only in the kind of presentation mode. Would it be possible to make it kind of like,
oh, that's so.
Yeah.
Yes, absolutely. Absolutely.
Thanks.
I was trying to figure out how I can see the presenter mode while sharing with you the non-presenter mode, but it turns out that that is not possible if you have a single screen, I guess.
Yeah, sadly, it's only with 2 screens.
Yeah, that's such a pity. Is
Yes.
this better now?
That's perfect. Thank you. Thanks a lot.
Okay, so let me see if we could figure this out. Okay, so again, projective mapping, 3-dimensional scene onto a 2-dimensional onto a 2-dimensional projective plane, and the issue with that is that if we want to monitor quantitatively monitor progress in surgery, or if we want to do longitudinal follow-ups with patients, then it becomes essentially a very qualitative task, because the viewpoints may change. Also, there is no scale in those images. So essentially measuring anything on the 2-dimensional projective plane is going to be complicated. And there, essentially doing this unprojection of the video sequence into a 3-dimensional reconstruction of the 3-dimensional scene is going to be beneficial, because it will result in a 3-dimensional model of the anatomy that we have scoped. And that allows us to do multiple interesting things. One thing is the quantitative measurement of things that we care about in that specific patient's anatomy. For example, the growth of a polyp as it reacts to topical treatment, something that we are interested in for longitudinal monitoring. The other direction that people may talk about also later in the context of augmented reality is, for example, that this 3-dimensional representation of the anatomy can benefit downstream tasks, like, for example, the registration of a preoperative model onto the intraoperative scene. It may allow us to do biomechanical simulation and modeling. It can allow us to do instrument tracking and all sorts of other things that we may care about in order to somehow assist the surgeons during the procedure. Now, oh, wonderful. Here we go. So this is not something that, so achieving 3-dimensional reconstruction from endoscopic video is not something that is particularly new. People have looked into this for quite some time, and there is a large thread of work that is trying to develop dedicated instrumentation and sensors and embed those into the endoscopes so that we can achieve direct measurement of the 3-dimensional anatomy immediately. So that has a lot of benefits. The biggest benefit perhaps is that this does not require any inference, because immediately you measure what you care about. And most of the technology that we see in this specific space uses structured illumination, which means that there is one sort of light source integrated into the sensor. It emits a light, usually it's in the infrared, so that humans don't perceive it. Can be structured, can simply be a pattern, can also have phase information and time of flight. And this then is decoded essentially to give you the 3-dimensional reconstruction. That's great, right? Now, since all of these advances have been made, these devices now are low cost. So some of us may have them in our homes. In endoscopes, that trend is also happening, but the problem is that some of these have still low resolution. Again, something that with more engineering efforts can be done, but it challenges adoption at the moment. There are some other problems that are a bit more fundamental, which will be hard to resolve just by a slightly more developments here. So one of them is the problem that these structured light sensors have quite substantial problems in presence of high brilliance illumination, right? So that may be the sun if you are in an outdoor environment, or it may be the surgical lightning, the surgical light that shines on the scene that you care about the most during an operation. So here what you can see is essentially the deterioration of a 3-dimensional reconstruction of the same scene without and with surgical lighting. And you can see that the data essentially here of the operating site is virtually unusable. The other problem that you will encounter is that because you have structured light, different surfaces have different reflection properties. Most of them are non-Lambertian. And what that does is it will introduce essentially material property specific systematic errors in the measurements that you get from these devices. So here you can see essentially the offset in depth taken from the top with a structured light camera, and then essentially visualized the position in a 90-degree offset position, and you can see that the surface, all of these material, the wooden table, the paper, and ABS plastics are placed on the same surface. They appear at different depths, and that's because of these systematic errors in measurement. The same happens, unfortunately, in human tissue. You can look in the paper for a little bit more information on that. But really, what it means is that if you use this for a downstream task, say registration, your registration is going to be wrong because the depth measurements that you get are already inaccurate. So we need a solution for this, and the solution that we can adopt here is stereo vision, where essentially now we don't have a dedicated sensor. We only have 2 cameras, and we use the light information that is in our scene. And by doing that, we can deal with the high brilliance light simply because we can adapt our exposure to the scene that we care about. And we will not get systematic errors, at least if we assume that some of the surfaces are Lambertian. There will be specularities, but we can deal with those. The issue is that now, rather than measuring 3D directly from our sensors, now we must infer the 3-dimensional information using some algorithmic processes. And I'm going to talk a little bit about some of our recent work in trying to do that using some of the modern architectures that we have for machine learning, which are transformers. So in stereogeometry, the setup that we talk about are essentially 2 calibrated cameras. We have a left camera and a right camera. And from 2D stereogeometry, what we know is that there is essentially this that points that lie in that space essentially will create, together with the camera centers, a plane that spans the 3D space, and this plane will intersect the 2 image planes that you can see here in green in 2 lines. And this line that are corresponding because they result from the same 3-dimensional plane intersecting with the 2 camera planes, we will call epipolar lines. And the reason why these epipolar lines are important is because of the way how we constructed it, using one specific 3D point and the intersection of the camera planes. So what that means is that essentially points that appear somewhere in the 3D space will be constrained to these 2 lines, right? So if I find a point in the left in my left image coordinate frame, and I know the calibrated camera parameters, then I can define a line in the other image plane on which that specific corresponding point must lie. And that's going to be important because we're going to use this to reformulate our correspondence matching problem between left and right image, right? So this correspondence estimation problem, taking a point in the left image and finding the corresponding point in the right one, is called disparity estimation. And this allows us, because of this geometric relationship that is visualized here on the slide, allows us to triangulate from that knowledge the 3-dimensional position of that point. And if we do that for all the points that we have in our images, we will result in a reconstruction of the 3D scene. Now, that sounds reasonably straightforward. So far, it's mostly geometry. But the issue with that is that this densely matching points between the left and the right image of an unconstrained scene turns out to be a very complicated problem. Now, people have worked on this for quite some time, and there are solutions for this matching problem out there. A lot of the approaches that exist right now, irrespective of whether they are learning-based or conventional image description based, perform matching independently, which essentially means that I take a point in my left image and I search the corresponding point in my right image, and I repeat that for all my points. And it turns out that if we do that, we achieve reasonably good performance, but in some cases, we will encounter problems. And those problems occur mostly in scenarios that turn out to be traditionally challenging, like limited textures, repetitive textures, very few features. And on top of that, we will encounter challenges in enforcing geometric constraints. Like, for example, that points need to appear in an ordered way, that there is uniqueness, and for example, that there may be occlusion depending on the 3-dimensional scene and our two cameras. So if independent matching of these points is responsible for some of the challenges that we find today, maybe we shouldn't be matching points independently. Maybe we should match them somehow concurrently, right? With sharing information across how other points match. And it turns out that That then results in a dynamic programming problem. And if we do that simply because we now match the whole sequence and we essentially match points concurrently, we are able to enforce these geometric constraints simply because we can share information about what other points did and where other points matched to. Now, this idea is not necessarily new. In fact, the idea was, to our knowledge, first proposed in 1985 by Ota and Kanade. There may be earlier methods, we haven't found those, but the methods, even though they were researched for quite some time, there is an occasional paper here and there that follows these ideas. They didn't really, they didn't really stuck around. People have adopted other methods, and the reason for that is probably because the methods that we had up to date are very much local. Right, so the sequence-to-sequence matching, if we don't have other tools, still relies on local information. So the amount of information that can be shared is very limited. So they didn't really stick around. So nowadays we do have novel tools. We have deep neural networks, deep convolutional neural networks. Now we have also transformer models, and these models can acquire local, but also the global context. So perhaps what we should be doing is we should revisit this type of architectures to see whether with novel tools we can do a little bit better than before. So as I said before, one of the reasons why this failed in the beginning was the lack of global context in the sequence-to-sequence matching task. So what we're going to do here first is we're going to take our left and our right image, between which we want to establish the correspondences, and we're going to run them through a deep convolutional neural network. This is essentially an hourglass-like structure where we encode and then decode so that we get a feature representation of the left and the right image respectively. This is a relatively deep neural network, so this has a large receptive field, which means that after we have encoded and decoded our feature representations, essentially every pixel will have a representation that is now built not only from local context, but has acquired through the receptive field a more global context and global representation of what information we will find in the scene. Based on these feature representations that we have of left and right image, we now go ahead and deploy a transformer architecture that essentially consists of 6 alternating self and cross attention layers that run with relative position encoding. Now, you may know that transformers are rather memory hungry. So rather than doing this now, this matching using the transformer on the complete images, we do this on the structure that I introduced earlier, which is the epipolar line. So we extract the epipolar line, the epipolar lines in the left and the right image, and we match the points in the sequence to sequence on those 2 specific epipolar lines in a dynamic programming-like problem that we now solve using inference, using a transformer model. So really what happens here is we have a self-attention layer, right? We take our responses and or our feature representations in that specific image. We compute a self-attention to update our representations. After that, we perform a cross-attention to update our representations based on information that we find in the other image. And this is how we alternate. At the very end, once we have developed these representations, we're essentially computing one last cross attention in order to get the final position assignments for the corresponding points. And this is then followed by an optimal transport layer that is also differentiable. And after that, we perform context adjustment. The reason why we do context adjustment is because of 2 specific reasons. One reason mostly actually is that, as I said earlier, we match on epipolar lines, which means that individual epipolar lines that are positioned below one another in the image do not share information. So in order to essentially harmonize and so like artifact reduce our final output, we perform and process this once with this context adjustment layer. Now, doing it this way is interesting because this very last layer, the soft assignment, allows us to introduce dustbins, which means that we can very explicitly assign occlusion, for example, to certain pixels that simply the depth here is not observed. We can also enforce that the attention in this last cross attention module needs to be limited. So it's essentially an upper triangular matrix where we can say that because we know that pixels in the right image must always appear left of the corresponding point, we can essentially mask the attention and never consider pixels that would violate this geometric assumption. And we can enforce the uniqueness constraint of the match simply because we need to solve this optimal transport problem. There are a few tricks here, because if we look closely at the imaging problem sizes that we have here and the number of heads that we have in our attention, then one single attention layer would end up being around 250 gigabytes of memory, which clearly doesn't fit in most of the commercially available GPUs that we have in the labs. So there are a few tricks that we apply. One of which is we don't compute the attention module with a stride of 1, but we skip 3 pixels. We do gradient checkpointing so that we don't have to memorize all our representations at the time when we do backpropagation. And then we run asymmetric augmentation. And doing all of this essentially reduce the memory footprint to a more tractable 8 gigabytes per attention layer. And the asymmetric augmentation introduces the robustness of our overall model. So this here is essentially some visualization results of the data sets on which we train this architecture, which is the scene flow fly things 3D. It's a very large synthetic data set that has ground truth available, so it lends itself quite well for training. And the one thing that we found very interesting in visualization is the animation on the top right, which essentially visualizes the self-attention and the cross-attention for one specific point of interest that is located in a feature-less area, this large table, right, where there is no local texture. And what you can see is that in the very early layers, the attention starts very broadly, where it is unclear which pixels in the same and in the corresponding image that specific pixel should be attending to. But as we move through the inference layers, as we go deeper in our network, you will find that the attention mechanism essentially reduces and focuses first on very distinctive structures in the image, like the edges, which turn out to be helpful due to the positional encoding that we have in our network, right? So we can compute relative distances with respect to such points, and towards the end converges to the corresponding location in the real image, right? The effect of positional encoding that I already mentioned in the top right image is also visualized in the bottom left, where essentially you can see an RGB color embedding using, I think we use t-SNE of the representations into a color space that can be represented as an RGB image. And you can see that as we go deeper and use more attention layers, the positional encoding introduces these patterns that essentially are parallel to our edges and essentially help disambiguate matches across textureless surfaces. So the method that we described here performs reasonably well. We achieve quite high performance on the data set that we trained this on. But what we think is even more important and more interesting is the fact that the algorithm generalizes very, very well from that purely synthetic data set to other data sets that are not synthetic, like, for example, Kitty, Middlebury, or Scared, which is a clinical data set which this community probably cares about the most. I will not go too much into the details here because I think I want to show you just how well this works without retraining on clinical data. So what you can see here on the top left is essentially some drilling into a Facon phantom of the skull base with results that are achieved exactly with this model without retraining. So this is the model out of the box, as you can download it from GitHub. The same also happens with Scared, where you can see a rather satisfying three-dimensional reconstruction performance, again, simply out of the box, without any retraining. Okay. Since we have developed this model, now we're using it quite a bit in all sorts of different tasks. So this right here is something that we will present at MICAI this year, where we're interested in recovering the three-dimensional scene behind the tools, so that we can essentially in 3D disambiguate between what is behind the tools over time. So essentially, we take the current scene, we try to reconstruct the three-dimensional scene by occluding, or by trying to estimate what is behind the tools. And this here again runs the algorithm that I was just talking about without refinement on clinical data taken from our collaborators at CUHK. And then, because we're here in an augmented, have a notion of augmented reality as well, I wanted to show you another use case that we're using this algorithm for right now, which is essentially trying to guide total shoulder arthroplasty, where we have found that, as I started my talk in the very beginning, using structured light sensors doesn't give us good enough information to perform image-based registration of the preoperative plan and the intraoperative anatomy. So right now we're also employing the data that, or essentially we're also employing the architecture and network that I just talked about, trained on synthetic data exactly here on these scenes in order to reconstruct the three-dimensional environment. So the method that I talked about here, right, is a sequence-to-sequence matching approach for depth estimation from stereo cameras. One thing I should notice, and so on, is that the method that I talked about, we call it STTR, stereo transformer, is not in fact state of the art. So when you look at retraining on Kitty, for example, and other data sets, there are other methods out there, for example, on neural architecture search and so on, that easily outperform the method that we have developed here. And in the beginning, we were a bit sad about that because SOTA seems so important. But then we asked ourselves whether we should actually care. And we decided that we probably shouldn't care as much. Because if we look at how we establish state-of-the-art these days, is on data sets like Kitty 2015, where the test data set is 200 images large, on Scare that has 315 images from very similar scenes, and Middlebury that consists of 15 images. So the question is, right, you can probably run a power analysis, although we'll find that we have a hard time to estimate how representative of the real world these images truly are. So really, we're comparing models that have very, very similar performance on data sets that are reasonably small. So reliably judging the ranking of certain algorithms is going to be complicated as we continue this research, right? And we should probably think about better ways of estimating whether we really are at a point where we can be satisfied with our development accuracy or whether we need to do more work. Because in turn, while we are not achieving state of the art, what our algorithm allows us to do is it allows us to enforce geometric constraints, for example, occlusion, which turns out to be very important for downstream tasks, and essentially confidence of match, which again, if you consider registration, may be a very useful information to have if you want to solve that problem. And it generalizes well. We take our algorithm and without retraining apply it to all sorts of problems, right? Which is something that we have found suits our needs quite well and fits very well in the use cases that people in my lab care about and work on. So I figured I should close with this. I'm not really sure, how am I doing on time? Do I have 2 minutes for something interesting?
Yeah, please go ahead. We have time, I think. So.
Wonderful. I have 2 thank you slides because I wasn't sure how I will be doing. So here is the appendix A. One thing I wanted to briefly bring up, because this is something that we have noticed in internal developments and have now put it together in the form of a paper and try to see whether people will like it. But I figured I should talk about it here, is that in everything that I talked about earlier, I mentioned that we are not refining the model that we have on the data set use case for that specific method. And of course, the first question that you could ask is, why are you not refining it, right? You would expect your model to perform even better if you refine it. And the answer to that is, yeah, well, that's probably true. But in order to refine your model, you probably need ground truth depth information, right? If you don't have that, it will be hard to retrain. And we don't necessarily have ground truth depth information because we're trying to develop novel workflows for which we have never acquired data before, let alone acquired ground truth. So that is not feasible. So, okay, then you may ask, well, there is all this body of work on self-supervised depth estimation, right? For example, with image synthesis, which people have invested quite a lot of thought in. Why don't you use that? And this answer is slightly more complicated. So the idea behind image synthesis is that so if we have 2 observations of the same scene as we had before, right? Left image and right image, they observe the exact same 3-dimensional scene. Then if I want to be able to reconstruct one of the images, take the left image and warp it so that it recreates my right image, in order to do that, I need to estimate depth. And the better my depth is estimated, the better I will be able to reconstruct, to synthesize the right image from the left and vice versa, okay? So essentially, image synthesis, reconstructing one image from the other, can be considered a proxy task for depth estimation. And this has been used extensively in the literature. I think we have identified approximately 150 papers that use this specific idea to do self-supervised refinement or self-supervised depth estimation in the first place in either stereo or monocular settings. So this idea is very prevalent. What's interesting is that most of the time, this setup is used in cases where you do not actually have three-dimensional ground truth, right? So you will never evaluate with respect to what your network does with respect to depth. And here's something interesting. The thing that we found is that if you have a network that generalizes reasonably well, then optimizing for this specific criterion, the synthesis, may actually make your depth estimation performance worse, right? So essentially, you converge with respect to your image synthesis objective, right? I mean, you can see this here, right? So this is plotted, for example, for Kitty in the green box for Kitty 2015, right? the middle line is our training and optimal performance curves over time. In the middle, we see image synthesis. So how well we reconstruct one image from the other. This is the only information that usually you have available to you if you solve a true unsupervised learning problem. And then the left-hand side, what you can see is you can see your error with respect to the depth objective. Okay, this is the proxy objective that you actually want to optimize. And what you will find is that as you optimize for image synthesis loss, it happens in many of these cases actually that your loss objective with respect to depth diverges, right? So you end up with something after convergence of your image synthesis loss, you end up with a depth estimation performance that is worse than what you started with. And the reason why this is problematic is because you don't know, right? In most of your cases, you start with, you have an unsupervised learning problem, so you don't actually know whether you will be improving or whether you get worse using image synthesis loss alone. Now, there are many questions that you may have in this regard. Is this the same for all sorts of formulations of the image synthesis loss? Is it this, is it that? And I can tell you, yes. But if you wanna know more, right now this is not out yet, but it's a paper with I think 20 pages appendix on all these types of conditions here. And it's a challenge that we have observed across a large range of cases, which is why at this point in time, we're not refining our algorithms because we have found that it actually makes depth estimation worse. I thought this was an interesting thing to talk about briefly. All right.
Yes, it was very interesting. Yeah.
This was the end. Thank you very much.
Thanks a lot. So if there are questions, we can take one or two questions as time might allow us to do so. So if there are questions, I don't see any question. So from the panel, if you have any question, please pose the question directly to Matthias. And the attendees can post the question on the Q&A section. So if you have any question, please feel free to do so. So Matthias, I have one question for you. So I also kind of work on 3D. So there are a lot of failure modes. Have you encountered some failure modes? We always see the success stories, but were there any failure modes in your experiments which you think, because of certain challenges, it was that opens up new avenues also to do research, right? So
yeah, so I think I think this is interesting. So essentially, there are lots of failure modes that exist. For example, I was talking about positional encoding. In the beginning, we started to use not relative position encoding, but absolute position encoding, and it turns out that doesn't work. It will dramatically overfit to the problem that you have at hand. So that's one of the things. The other thing that I thought was a bit more interesting is this thing that I talked about last. Because in reality, what we wanted to do is we wanted to take our algorithm and do unsupervised refinement on surgical scenes so that we can get better. And we found out that we're just not getting better, we're getting worse. And then we wanted to understand why that was happening. And this led to what I talked about at the very end, with lots and lots of experiments to see when it happens, if it happens, and so on. So yeah, I think that's one of those failure stories.
That's a very interesting point, by the way. I'm looking forward for the whole paper and the 20-page appendix. So thank you a lot for the extra slides. So do we have any questions? You can write in the Q&A box. Okay, there's one question by Wu. Monoculture to obtain naked eye 2D. I'm not sure, but can you elaborate on your question?
All right, I think the question is not that clear. So, so I think if there is no more questions, so we should proceed as the time, we have very limited time now. So I think, so I would now hand over to Dvigu to introduce our next keynote speakers.
Okay, maybe we can rephrase the question and we can take it at the
later
panel session. So our next speaker is Adrian Bartoli, and he has held the position of Professor of Computer Science at Université Clermont-Auvergne since fall 2009, and has been a member of Institut Universitaire de France. And he leads the endoscopy and computer vision research group at the University and Hospital of Clermont-Ferrand. His main research interests are in computer vision, including image registration and shape from X, such as silhouettes, shading, texture, etc., for rigid and deformable environments, and their application to computer-aided medical interventions. And he will be presenting today the laparoscopic augmented reality from preoperative image data.
Hi, so thanks for the introduction and the invitation to speak today in this symposium. So I've just shared my presentation. You should be able to see it. So this is joint work with many of my colleagues in my research group, which include surgeons, radiologists, and of course PhD students and postdocs in 3D vision. This is the content of my presentation. So I'll start with a brief introduction to laparoscopy and augmented laparoscopy. Then I'll talk of the liver case, of the problem of validating the system. Then I'll discuss the uterus and the kidney cases briefly and outline future work in this area. So laparoscopy, as I'm sure you're well aware, is a technique of doing endoscopic surgery in the abdominopelvic cavity. And you can see an example here of the operating theater on the left with a surgeon doing laparoscopy in a liver procedure in this case. So you can see the two laparoscopy screens facing the surgeon. They show the same image. And on the left, you can see the laparoscopic ultrasound console, which is used to find some of the internal organ structures. On the right, you can see the typical setup. So you typically have an assistant holding the laparoscopic camera and the surgeon holding two tools, entering through 3 or more keyholes sometimes. So one of the main limits of laparoscopy is the ability to, or the inability to touch rather the organs directly with the hands by the surgeon. So the main problem with this is that they have difficulties identifying the location of some of the internal structures. If you look at these two images, so you have a uterus on the left and the liver on the right. And we know from preoperative examination that there are tumors or structures to be removed in these organs. Nevertheless, because they are not transparent, we can't see exactly where these structures are because they are internal. And this may cause problems during surgery because some of the tumors, they may be difficult to find. And some of the structures like vessels, they shouldn't be touched, they should be preserved. And if they're cut, that could be an emergency. Then the procedure should be converted to open surgery, to laparotomy, which is potentially complex and long. And we identified that a help to this problem could be by improving visualization. And so the central question I'm going to discuss in this presentation is how can we improve laparoscopic visualization to help the surgeon find the internal structures such as tumors. And the key idea that we're going to exploit is to change the image in live laparoscopy. So if we look at the workflow of laparoscopy, typically the patients go through imaging before surgery to make diagnosis, and this imaging is either ultrasound, MR, or CT, etc. And it typically produces a volume of data. And the surgeon or the radiologist use this data to make a diagnosis and sends the patient to surgery or not. This data is still here during surgery. However, it's shown to the doctor, to the surgeon on a separate screen, not on the same screen as laparoscopy. And so it's used mostly as a memory, as a mental map of where the structures are. And it's really difficult for the surgeon to use it precisely to guide the gesture. So what we thought could be interesting would be to merge this preoperative data with the live laparoscopic video feed in real time during surgery. And to display with this merging additional elements directly on the laparoscopy screen. And you can see in this example, so that's a liver procedure. We have added tumors in yellow and the vessel branch in blue during surgery on the laparoscopy screen. We call this concept augmented laparoscopy. So the equation we have to resolve is the following one. We have preoperative CT or MR or any other preoperative examination that we want to merge with a laparoscopy image or a laparoscopy video stream to give the augmented laparoscopy image or video stream. So that's a complex problem because it's multimodal. We have CT and optical modalities to merge. We don't have fixed structures such as bones, and we have very few landmarks for an organ as the liver, typically. We have deformations because, as you know, at the start of laparoscopy, the abdominal cavity is inflated with CO2, so that changes the intra-abdominal pressure that makes deformations. And of course, the surgeon interacts with the organs, which also causes deformations. So that's a challenging problem, and we don't want to misguide the surgeon to the wrong place, of course. So this was the problem. Now, how can we achieve this type of augmentation for the liver? As you will see, there are specificities, of course, to each and every organ that we want to handle. So on the top, you have this equation we want to resolve. And we first start by modeling the laparoscope. And for that, we use a classical pinhole camera model, which is perspective projection. And we assume that this can be calibrated with a checkerboard at the start of surgery. This is a state-of-the-art camera calibration. So we can put this laparoscopy image within a camera coordinate frame. Of course, it's still a 2D image, but it's in the camera coordinates. And we have to find this arrow here, this black arrow that maps from the coordinate frames of the preoperative CT in the preoperative states to the intraoperative state in camera coordinates. And mathematically, this means that we have to resolve for a 3D deformation field from the N to the 3 voxels of the CT image, CT volume, to the camera coordinate frame. So this deformation field handles both the deformation of the patient, of the organ, and the pose of the camera. So it brings the data, it deforms it and brings it to camera coordinates. And everything is in this single deformation field. So that's what we have to resolve from the data. So in order to resolve this, of course, like I said, we assume we have known intrinsic calibration to the camera. Still, the problem is very ill conditions. We have very little data to resolve it. So we must find additional constraints to solve it. And the key idea is we are going to use the visible part of the organ. Of course, most of the organ is invisible. We only see the outer part, and we're going to use this outer part to bring constraints and try to resolve this constraint to extrapolate the whole deformation field. Once we have this whole deformation field, we'll apply it to the internal parts of the organs, which are the ones we're really interested in order to bring new visualization to the surgeon. Of course, the surgeon sees the outer part of the organ. They don't need augmentation of these. They need augmentation on the inner parts. So that's an inference problem where we see a little part of the organ, just the envelope of it. From it, we infer the whole deformation field. And from this deformation field, we deform the parts which are inside, the invisible ones that we're really interested in. So now the question is how to infer from the outer part of the organ the 3D deformation field. So for that, we use 3 different types of constraints. The first type is the biomechanics, which says that the organ cannot deform arbitrarily. It must follow some sound rule of deformations, which were very well studied and are very well known. Typically, this prevents large deformations and strong shearing and these sorts of things. And we implement it via finite elements of the organ that we create on the CT data directly. Then the second type of constraints we have are represented by anatomical landmarks. So these are fixed locations that we can actually find both in the CT and in our input laparoscopy data. It highly depends on the organ, of course. So for the liver, we have identified 3 of them. One is the ligament that holds the liver to the abdominal wall. This ligament is typically cut at the start of surgery, and you can see the scar on the surface of the liver. It's actually here. It separates the liver into its 2 main lobes. So that's the one we can find into the image quite easily. So either we can mark it manually or we can use deep learning to find it. And we can also see it in the CT. So that's a good landmark. It's almost always visible. That's a good one. And then we have a second one, which is the lower ridge of the liver. So that's typically where the liver has a very high curvature. You can see it here at the bottom of the image. And this bottom ridge, of course, is also visible in the CT and is typically split in 2 parts. And we can use the 2 parts to build 2 different landmarks to achieve registration. And finally, the last type of constraints are built from visual cues, which are what we can extract from the image to tell us something about the 3D, right? To constrain the deformed state of the liver in camera coordinates directly. And we have exploited several types of visual cues, which are known from the literature. The first type is the silhouette of the organ. We can also find it by deep learning in the input image or mark it manually. Once we have this silhouette, it's a very important constraint on the deformed state of the liver because it says that the silhouette predicted by the deformed state of the liver should match the one which we observed in the image. And the second important visual cue we use from the liver, from the image is shading, which is very effective in laparoscopy because we can calibrate the light source of the laparoscope. So we know where the light source is with respect to the camera objective, with respect to the camera lens. So because we know that, we can build a strong shading model. And by measuring the local amount of light received in small pixel patches, we can infer more or less the angle between this patch, this surface element in 3D, and the light vector. And this also gives a strong constraint on the deformed organ. So I'm now presenting quickly a surgical case where we use this procedure. So On the left, you can see a slice of the CT scan, of the preoperative CT scan. You can see the outline of the liver in red and the outline of two tumors in red and green on the bottom left. So in this case, the two tumors were endophytic, which means they're internal and not visible. So as you can see on the right image, indeed, we don't know where the tumors are. Even for an experienced surgeon, this is a challenging case. Typically, they would use laparoscopic ultrasound to help them find the tumors, but in this case, it wasn't working because of strong artifacts. And so we performed augmented reality, and so the movie is not working for some reason, but what you can see, what you should see, is a deformation of the preoperative model live to fit the image. So on the image, you can see the silhouette that I was talking about in yellow, and the lower ridge here in red. And what you should see is the model being deformed to fit this. If I have time at the end, I'll restart my PowerPoint to be able to show you the video, or perhaps I can try non-presentation mode quickly. Okay. Let me know if you still see my screen. Well, it says it cannot play, so sorry about that, and I'll try later. It was working, of course, just before starting the presentation. The joy of PowerPoints. So anyways, that's the results on the middle top image. You can see here a prediction of the two tumors from the CT. That was a particularly difficult case because they couldn't use ultrasound and because they had done a round of chemotherapy before surgery. So the two tumors, which we could easily spot in the CT scan, shrunk dramatically. So that was a good thing for the patient, of course, but they couldn't locate the tumor, and still they had to remove the tissue around the tumors, even if they shrunk considerably. So they were basically blind, and that helped them a lot to be able to see these two tumors. And we did a second round of augmentation after they started to resect the piece of liver. And we could verify in post-operative histology that they had started to resect too close to the tumor, and thanks to augmented reality, they could enlarge the piece of liver to be resected and manage to make a much better resection than without augmented reality. So we have implemented this theory in a software we call Hepatog. So that's a contraction of hepatic surgery and augmented reality. And you can see a screenshot of our software, which runs in the operating theater here on the left screen. So it allows for this automatic registration that I've presented and some manual corrections using control points on the model. So it's quite an advanced software. Of course, this is interesting only if this is accurate, and we have a huge challenge with the validation. How accurate is it? How accurate in terms of millimeters is our prediction of the tumor's position? So the ultimate goal is to aid surgery to benefit the patients, and for that we have a lot of clinical benefits that we can evaluate. But also an important criterion is how accurate we are in terms of 3D prediction in camera coordinates. And this is very difficult to evaluate. This is, in my opinion, still an open problem. It's doable on phantoms and animals, whether dead or live animals, whether ex vivo or in vivo, but still doing this in a real clinical setting in the operating theater is still an open challenge. And we're trying to address this currently in my group by combining different imaging modalities. So that's the evaluation models we can use to evaluate these type of technologies. It goes from digital models where everything is simulated to clinical models. Of course, the digital models are weak in terms of realism, and the clinical models are strong, but the implementation is opposite to this. If you simulate a model, you have access to everything, including ground truth. which is not possible in clinical models by definition, because in clinical models, if you had access to ground truth using a different medium, you wouldn't need augmented reality in the first place. So ground truth is in general not accessible, making validation really difficult. In terms of other organs, we've also worked on the case of the uterus. So we have to translate our initial equation on the liver on the uterus case. So you can see here an MRI of the uterus with two tumors here as well, a big one and a small one, and a laparoscopic image of the uterus and the type of augmentation we do in this case here with a big tumor in green and the small one at the back here in blue. So the difference with the liver is, of course, we don't have the same landmarks to register. And here I wanted to show you a video that shows how much the liver deforms strongly, but the video doesn't play for some reason. And here a video of the uterus, which shows how much it is, how close it is to behave quasi-rigidly, at least at the start of surgery. And another important thing is that it can be manipulated from the outside of the body using a cannula through the vagina, which is of course not possible for the liver, which is not reachable from the outside except through the keyhole, which is a different thing. So because the uterus is rigid, we're able to track it live at frame rates and carry over the augmentation, the registration we make on a reference image, to a real-time video stream. I cannot show you the video again, that's too bad, and I'll show it later. This was another video showing the uterus augmented reality live in the operating theater. And another one showing the augmentation on a different case where we have augmented the uterine cavity, because that's a very important structure to spare for the surgeon for future pregnancies of the patients. Another case of resection, successful resection of an internal tumor in the uterus. And an interesting test we made using diffusion MRI, which is usually not acquired on the uterus, but which we actually used to reconstruct the muscles fibers of the uterus preoperatively. Usually it's used for the brain, and we've used it for the uterus, and then we augmented these fibers live during surgery. So the hypothesis we made here is that if the surgeon would actually incise along the fibers rather than orthogonally to the fibers, the healing process would be improved. We haven't validated this hypothesis yet, and this is an ongoing work, but quite interesting, I must say. And finally, the case of the kidneys, I cannot show you again the video, so you can't see anything, but hopefully I can show it afterwards. And some ideas for future work. Of course, I've talked briefly about it. Validation is still required more than ever because we have prototypes. They're being used in our hospital in the OR, so we need a stricter validation of the technology itself rather than just the clinical outcomes. We need to expand to more organs and types of procedures. So I've discussed 3 organs, but however, at the moment, we just do a tiny set of procedures and we would like to expand to others. Next, of course, to industrialize. This is important if we want to make it to the OR at the wider scale, of course. Develop new ideas. As soon as the surgeon starts to incise, of course, the deformations are dramatically more complex to handle for the registration part. So there is some new theory which is needed there because we need to update the topology of the preoperative model if we want to be able to register it properly. And finally, the prototypes we've made, they still require some surgeon interactions, even though they're still mild. we need to make this automatic to reduce the disruption of the surgical workflow to the minimum. All right, so thanks for listening, and we'll be very happy to address the questions.
Thank you, Adrian. I think we have some time if you want to try to show the videos. And if you have questions, please write it in the Q&A so that I can ask them to our speaker. So there's a question, but it's very generic, I think. So they're asking whether the human anatomy always change. And I think there's a definite yes, but if you would like to add something on it, Adrian, you are welcome to.
I didn't hear the question very well. I'm sorry.
So I think there is some concern like this when we're wondering. So Siri has written, does the human anatomy always change? And I think it's a clear yes, but maybe how much is his question or her question?
How much does it change?
If you can, okay, I'm really confused, but okay, maybe you can elaborate on it on the question so it's more clear.
Okay.
And Ram Kumar is asking, so if I think this is better suited for the panel discussion, but if there are any funding resources in this kind of area, maybe we can take it to the panel discussion.
Yeah, sure. So for the first question, I think it does always change quite a lot, especially because of sickness. Sometimes, you know, the disease can create odd shapes to the organs, and this makes sometimes registration much more difficult. Sometimes we can't see the usual anatomical landmarks. So
maybe
yeah.
age is also a factor, would you say? Okay.
Yeah, right, definitely. Yeah. And probably for the other question, I think you're right, it's better to left it for the panel discussion.
Okay. And View is asking how accurate is intraoperative navigation of AR on soft tissue. So we mentioned how deformable the liver is. So for example, how do you handle the accuracy if you want to check how your model is performing?
Yeah. Well, the order is centimeter, right? The Roth order. So it could be less accurate, it could be more accurate depending on the case, of course, depending on the anatomy of the patient. We've made measurements on animals, on phantoms where we have ground truth. You know, for an animal, we can use an extra sensor to monitor ground truth and of course simulated environments, and we're about a centimeter accurate.
And how sensitive would you say your model is? Like some anonymous person is asking, so they have included their name. So, so would you say it's like 1 centimeter? Could be a lot, right? So if you are working with a tumor, you definitely want your model to be very sensitive. So if you are measuring, so are you measuring the performance in terms of outcome, maybe, instead of these millimetric accuracies?
Yeah, so that's an interesting question, because I mean the target application is of course to guide the surgeon as accurately as possible to find a tumor, but also roughly to where the tumor is. I mean, which part of the liver, because sometimes for some reason they would have real difficulties. It's a real challenging environment. They have real difficulties finding the proper orientation, and they would remove a very large part of the liver to make sure that the tumor is included, and or sometimes they would just remove the wrong part, unfortunately, and not that often, of course, but just saying this is roughly here is a huge help sometimes in some procedures.
Okay. And James is wondering, were there any specific reasons for choosing the organs and not the others? So we talk about the liver and the uterus.
Yeah. Yeah, that's a good question. I mean, we have to start with something, right? The liver is a good case because the amount of laparoscopy is not very high. It's about 20 to 30% of procedures. I mean, the other procedures are done with open surgery. And the main reason is that in case of emergency on the liver, converting to an open surgery is very complex because of the rib cage and you know, other specificities of the organ. So many surgeons find it very difficult and challenging. And we think that the impact could be major if we could bring a tool that says, well, you know, the tumor is here and there is a vessel, so you shouldn't cut there. And so we think the impact on healthcare could be major. So that's why the liver is an important case.
Okay, thank you. And our attendees say that it's a very interesting work, and we would like to thank you as well.
So let me see quickly if I have a few minutes to play the videos.
For the videos, yeah.
Yeah.
I think our attendees are also wondering about that.
So let me see.
Maybe if you have the source video somewhere. Okay, I think it's working.
It's working. So that's the fitting video of the registration. So this blue mesh is the outer surface of the liver as reconstructed from the CT. The yellow is for the two tumors and the blue for the vessels. I'll play it again. So you can see it starts from a very different configuration, really, and then it deforms to match the image constraints. In practice, it takes about 1 minute, this fitting, and we're working on making it faster because it takes place in the operating theater, and time is critical, of course. And let me find the other ones. So these were the ones showing how deformable the liver is. You can see as it's being manipulated, is very deformable. So it bends in all different sorts of ways, and it's really difficult to update the registration live. Though this is the uterus here, is being manipulated from the outside with the cannula. You can see it behaves fairly rigidly, so that makes it a very nice case for live augmented reality. And this is the result of this live augmented reality. So as it's being moved and handled from the outside, we are able to track it. And so this is tracking by detection. So even if the laparoscope goes outside of the body, or the organ goes outside the field of view, still it catches up directly. And this is frame rate. And finally, I think, yes, I had a couple here on the operating theater with this. So you can see here the regular, on the right, the regular laparoscopy view, and the one with augmented reality. So we have a tumor here, augmented. And the surgeon is being guided by this augmentation. This is another one, the one where we show the uterine cavity in black with a connection to the fallopian tubes here and there, and the two tumors are in yellow. The big one was very close here to the cavity, so it was a challenging case. And this is the case with the adenomyoma. So these are typically very small tumors of the uterus, which are difficult to find. And here you can see when they cut the organ. I'm going to make it a bit faster. The tumor was right exactly underneath the augmentation. So we were very happy. There it is. We were very happy about this case. and these are two cases with the fiber augmentation. This is something they can't see really at all during surgery, whatever they do, because this is just invisible to the naked eye and to the sensor. So this is what they could see with the augmentation. And I think the last one would be with the kidney. So here in this case, we use the robots, the Da Vinci robots, and you can see the augmentation here on the left. So this is the pedicle, the mesh is the surface, and that would be the pedicle here in red, and I think the gray part was the tumor to be resected. So visualization is not perfect. That's of course, one of the things we have to improve, because augmented reality has been used a lot to overlay something onto something. I mean, outside of, but outside of, and here we have to overlay something which is supposed to be inside and try to convey a sense of depth as much as we can, which is really challenging. We could, segment the tools and try to overlay the augmentation behind the tools and not on top of it to make it even more realistic, these sorts of things. Well, so I think that's pretty much it.
Okay, thank you very much for this interesting talk, and definitely the videos help a lot to understand. I think that's the whole point of AR as well. So we have the third speaker, and I will leave it to Shoaib to introduce her.
Thanks, Adrian. It was really great, and I could keep watching it. It was really cool to see it in surgery in the room itself. That's really amazing. So I think we are very kind of delighted to welcome Marta Kirsten Ortel, who is an assistant professor at the Concordia University in Montreal, Canada, and she completed her PhD in 2015 in biomedical engineering at McGill University, Montreal, and she also worked as a research assistant previously at University of Ottawa and University of Tübingen, Germany. And her research is focused on developing and evaluating new visualization, display, and interaction techniques in clinical context, which focus on image-guided surgery. So I think it's a very complimentary talk just after Adrian. And today her title talk is on exploring new visualization and interaction methods for more intuitive guidance in neurosurgery. We are looking forward for your talk, Marta. Welcome.
Thank you very much. So we'll just try to get that up and running. Okay, perfect. Could you see my slides?
Yes, we can see it. Thanks.
Excellent. So thank you for the introduction. And yes, I think Dr. Bertoli led really nicely into the theme of this talk. So today I'm going to be talking about how if we focus on how we should display and visualize data and how we can interact with the data, then we can develop more intuitive solutions for surgery that we hope will, improve surgical outcomes, aid surgeons in decision-making, particularly in terms of treatment strategies, and ultimately that will lead to improved patient outcomes. So at Concordia University, I'm the director of the Applied Perception Lab, which focuses on more the human-computer interaction components of clinical aspects. And so we're really focusing on, what are the best ways to visualize complex data, such as anatomical data? How should we display these, whether that's using head-mounted displays or tablets or 2D monitors? And how can interaction play a role in order to improve particular clinical tasks? And one of the things that we really try to focus on is actually bringing these technologies into the OR, testing them as well in the laboratory to see how they can benefit surgeons, clinical staff, and patients. And I guess I think I should mention that I personally think it's a very exciting time to be in the field because of all the new hardware that's becoming available. And it's becoming available and it's becoming more affordable. So things like head-mounted displays and all the different sensors that we can start trying to figure out how we can bring them into the clinical context and see what methods we can develop. So as mentioned in the title of the talk, the context I have been focusing on in my research is on image-guided neurosurgery. However, many of the themes you'll see here, of course, could be used in other clinical contexts and other types of surgical domains, and even outside of the operating room as well. And I guess I do want to motivate a little bit of why we think that this is important. And there's certainly shortcomings that have emerged as we've brought technology into the operating room. And so, for example, with guidance, when the surgeon is working, when it is working here in front of them and they're looking away for guidance, well, there's a disconnect between where they're looking and where they're working. And so it's important to determine, how detrimental is this disconnect. So we're looking at, how burdensome is the mapping between the images that are being shown on the guidance system and where the surgeon is working. And of course, surgeons are really good at doing this mapping, but that doesn't mean it's not trivial or that it might not disrupt the surgical workflow. And so this is, how the previous works have shown, where augmented reality, for example, might be useful. The data that we're dealing with is also very complex, whether that's vascular data or just the fact that we are getting more and more imaging data, and we have to figure out how to combine these different data sets into a way that we can understand them both spatially and in depth when we're doing things like augmented reality. And lastly, we want to improve surgical workflows. So one of the things I was kind of maybe shocked is a bit strong to say, but to see when I was going into the operating room was when a surgeon had to pause surgery and wait for a technician to come and work with the neuronavigation system to change the view or to change a few parameters because, there might be one technician or two technicians working for 4 operating rooms. And so there are definitely improvements that can be made in terms of surgical workflows. And then the other thing too is if we're bringing new tools and technologies into the operating room, well, we have to make sure that they do have a small footprint, that they do actually aid in the tasks that they're supposed to, and that they're not making things overly complicated, but rather simplifying and streamlining the surgical workflow. So based on these kind of issues, we've been looking, as I said, at things like how can we use augmented reality displays in neurosurgery? How can we, what benefits can tablets or iPhones have in the operating room? And we've also started looking at how virtual reality can be used for surgical planning prior to bringing, the technology into the OR. In terms of visualization, as I mentioned, one of the things we're focusing on is, when we have these complex medical scans, what's the best way to visualize them, whether that's preoperatively to determine treatment strategies or in the operating room in order to guide the surgeon with what they're doing. And we, as well as doing these tests and psychophysical examinations of how we render the data, we're also looking at, how can we use gamification to get more users to get more understanding of what the best rendering methods are. And for the third prong of this approach, we're looking at gestures. So how can we, improve workflows? How can we give the surgeon some control by using, for example, gestures on the tablet, allowing them to interact with the neuronavigation system by using the surgical pointer. We're also using things like sonification for surgical target localization or to kind of tell the surgeon where they are in space. And so these are kind of the different topics. And as I mentioned, one of the things that we're really trying to focus on is the end user, so the clinician. And so as well as getting qualitative feedback when we're going into the OR, we're also looking at, how can we use EEG to determine how the technology that we're trying to bring into the operating room is impacting cognitive load. We're also looking at how eye tracking can be used to determine fatigue. We haven't done this with clinicians yet, but we're developing models to look at these types of things. So really focusing on the end user. So all that to say is our goal is really to develop intuitive solutions that can facilitate these complex clinical tasks, that can blend into the surgical workflow in order to improve surgical outcomes and patient care. So I'm going to talk a little bit about some more specific projects we've been working on. So for example, augmented reality in image-guided neurosurgery. So as was mentioned by Dr. Bartoli, one of the issues when we're looking at augmented reality is that when we have a virtual object and we're trying to combine that with a real live view, well, it looks like the object is actually floating above is actually floating above the real world. And this isn't ideal. The tumor is obviously not above the cortex, it's below. But what we can do is we can start to think about how do we perceive depth in the real world, and how can we use these cues that our vision system use and bring these into, augmented reality or virtual reality. And so here, this is just a very simple method where, we're just retaining some of the edges from the real world, and we're using that to ensure that the tumor now looks like it's below the surface and not floating above the surface. And so actually a lot of my early work was really looking at, how do we visualize data? And we did a lot of work in the laboratory before bringing the system into the OR, and we found that actually depth cues that the visual system uses, such as fog or aerial perspective, such as chroma depth and edges and motion parallax, are very effective even in these types of contexts. And so we did a lot of work prior to going into the OR, and then we went into the OR and realized, okay, not all of these methods work, not all of these processing techniques work if we start considering that the real brain doesn't look like a phantom in the OR, and that we have bright OR lights to deal with. But we continued to go in and kind of improve the visualization, get feedback from the surgeons, and we found, there were certain methods that worked well. And we started looking, when we had that, we started looking, okay, when is augmented reality useful? So this is a case for a craniotomy. The video is sped up, where the surgeon would typically have to, map where the pointer is on the preoperative images, and then they would have to, make an outline to plan the craniotomy. However, this mapping no longer has to be done if you have the AR overlay, as was shown in this video. What we also found, as I mentioned, in terms of interaction, is if we allow the surgeon to actually control where the AR visualization is happening, well, this actually also gives them some sort of depth cue and control. Okay, here's where I'm seeing the tumor. Okay, here's how things are. So they can move around either the camera or use the pointer in our system to create kind of this AR window where they see it, to get a better spatial understanding of how the virtual elements are lying with respect to the real patient anatomy. So, oops, okay. So as we continued to bring the system in, we found, our goal was really, I'm sure AR isn't always useful, but when is it useful? What cases, what kind of tasks is it useful for? And what we found based on, preliminary tests of going into the OR is that at the beginning of the surgery, it's very useful for planning the craniotomy. So if you can see whether it's the tumor or the vasculature, and you can deal with that, then you can start to plan where you're going to make the incisions, where you're going to make the burr holes for the craniotomy. We also found on the cortex, it's very good, and a little later, it's very good for planning the resection corridor, to bring it to determine, how the surgeon wants to approach the surgery. We've also, so for example, I don't think you can see my mouse because I can't, but in the last image here for the resection, the surgeon had put a pink dot, which I hope you can see that on the AR view. And this was the vessel. This was a feeding vessel to an AVM that they wanted to target first. And so then they used the AR to find that vessel. They put a micro lentil on top of this and started planning, okay, how am I going to resect down to this first feeding artery to this AVM? And so these were some of the tasks that were useful. Of course, what happens when you start dissecting is that things start getting, the system is no longer precise. The brain has moved, the preoperative images are no longer mapping to the real world. And so one of the things that the work that's been being done at McGill is to use intraoperative ultrasound. So we combined intraoperative ultrasound with AR, not only to just account for the brain shift, but also to make sure that the surgeon can have a more accurate view for a longer amount of time. And so here you can see, we have an ultrasound image, we're registering it to the preoperative MR, and then we can account for some of the brain shift. In this case, actually, most of the brain shift, because the ultrasound was taken on top of the dura. And then we can create a more accurate augmented reality view, so that the guidance can be used for a longer amount of time. So all of the work that I've shown you so far has actually been done using an external camera, which of course, as I mentioned, is not ideal for the workflow. And even though, what that means is that the augmented reality visualization was actually still shown on the neuronavigation system on the monitor. And as I said, so this solves the problem of mapping the real world to the preoperative images, but it's not solving the problem of, I'm working on the patient here, but I'm looking far away for guidance. So we wanted to see, is there an impact in terms of, where the surgeon has to look for guidance? And so we decided that we would do this study that looked at focus shifts. Are focus shifts detrimental to the task at hand? Because this is something that in psychophysical experiments and human computer interaction experiments, and probably also your work, that if you are focusing on your work and then you go look at your iPhone for something, that's detrimental to the task you're doing at hand. And so we hypothesized that if we have the augmented reality display in front of the surgeon rather than on the neuronavigation system, then people would do better with this. And so specifically, we measured how 3 different types of systems would influence both focus shifts and the time to do a task. And the task was craniotomy planning. So it was tumor delineation. So the same tasks you saw the video where the surgeon was delineating a tumor. This is often done to plan the craniotomy. So we had the traditional system, so the 3 cut planes, which you don't see here, and the 3D view. We had the augmented reality view on the desktop computer, which is how we've been doing things so far. And then we had a mobile device where, you were looking essentially through the mobile device and doing the craniotomy planning. And what we found was that the number of attention shifts is significantly reduced when you're doing augmented reality versus using traditional navigation. But surprisingly, we did not find a significant difference between the desktop augmented reality and the mobile augmented reality. And the same thing was for time. There was a significant difference between traditional navigation and augmented reality, but not where the augmented reality was happening. That being said, in terms of subjective feedback, users felt more confident with augmented reality, more accurate. They found it more intuitive, and sorry, I have not switched my slide. And they also thought it was easier. There was less cognitive load. And this was especially the case with mobile AR versus desktop AR as well. So that being said, even though, the focus shifts were not significantly different, we still thought this was an interesting avenue of research. And so we decided to continue this, and we developed Marin, which is the mobile augmented reality interactive neuronavigator. And in terms of how Marin compares to other systems, one of the big things is that Marin is actually much quicker than previous systems, just because we're doing some really nice, we're using, modern video encoders, and we were able to kind of make it, most of the work is being done on the neuronavigation system, and then we're just sending things to an iPad in this case. So it's much faster than previous systems. And this has been shown that if you have latency in these types of systems, it makes it really unusable for users. So this was a really nice thing to see. It has few dependencies, and it's easily extensible as it's open source. And so I don't want to go into the details here, but just to show you that most of the grunt work is being done on the desktop computer. We're using the open source software IBIS. This could also be replaced with Slicer, however, if this is what other labs are using. And we're mostly rendering the images on the iPad and then sending any gesture commands back and doing more work. So this is, and one of the things I mentioned that we got a lot of positive feedback from the surgeons is that when they interact with the AR view, it gives them a better spatial understanding. And in this case, it's even more intuitive because we can use gestures to do things like show where the AR view is. We can pick points on it, and I'll show you a few other features that we're using gestures for. So one of the features is actually registration correction. So we thought, okay, we are putting the navigation system in the hands of the surgeon. What can we do? And one of the things, of course, is, well, the surgeon has all of the knowledge of all of the anatomy. So if there's a small misregistration, we can actually use the AR view to account for that registration. So Marin allows for a kind of manual registration correction using gestures. And we did a small study to see how good people would be doing at this. And we found that in terms of medium and large gestures, people can correct very well for this, but for when you have for medium and large displacements, misregistration between the preoperative and between the AR view and the preoperative images, subjects are really good at fixing that misregistration. But once that misregistration gets too small, so around 3 millimeters, oftentimes what happens is that they make the registration worse. There's a few reasons why this might be, but something that we'll be looking at in future work. Lastly, the last feature I just want to briefly mention for Marin is, so this was original work that was done at University of London or Robarts Institutes by our colleagues. So they developed a video-based hemodynamic analysis system. And in their work, they filter video sequences from a neurosurgical microscope, for example, in order to determine blood flow. And so this, you can imagine, can be really important in aneurysm cases or arterial venous malformations, where intraoperatively things, an artery might look like a vein, or a vein might look like an artery. And it's actually quite challenging to translate preoperative data to this small craniotomy scene. And so Vassallo et al.'s method had been tested on the microscope, and so we collaborated with them, trying to see, is it possible to actually use a lower resolution a lower resolution camera, the one from the iPad, and still be able to get this hemodynamic information. And so I won't go into the details, but essentially after some image stabilization and motion reduction, the image frames are being passed through a magnification filter that's occurring at the frequency range of a typical heart rate to determine flow directionality, which is really important, again, in neurovascular cases, sometimes when it's not easy to determine which way the blood is flowing. And so this was the setup. Another thing that, again, what we're doing, we have since we're using a tablet, what happens is that the surgeon can choose the vessel of interest. They can do this, just using gestures, as is shown here in the left, the upper left-hand image. They select a region of interest. The iPad tablet is running Marin. We're sending the information to the IBIS station, doing some processing, and then we send back the information and can augment the vessel with the direction of blood flow. So far we've done this using the vascular phantom from Xiao and Vassallo, and we're going to be looking at this, how well does it work in real clinical cases. Unfortunately, due to the pandemic, we haven't been able to do that yet. So, but in general, based on our preliminary studies, we found that yes, we do have sufficient resolution and frame rate from the iPad in order to determine blood flow directionality. We'll have to figure out, though, how small of a vessel we can do this for. The nice thing, again, is that the regions of interest can be defined intuitively using gestures on the mobile device itself and using the touch screen. So again, we don't have to rely on a technician to determine, okay, on this video, which vessel are we trying to get the information for? And then we can present the hemodynamic information in situ, so on the vessel, showing, exactly what's happening. So Marin is available, as I mentioned, open source if you're interested. And I just want to conclude with a little bit of future work on some of the things that we're working on. So again, I think one of the reasons that mobile devices might have a strong potential in neuronavigation and in the operating room is that they have a lot more sensors as well that we haven't even taken advantage of. So now we are looking at using LiDAR. This is actually some recent work that hopefully we'll be publishing soon, but there's other sensors as well. There's the accelerometer and gyroscope, and as I mentioned, the depth camera or the LiDAR, and we can try to explore how these different information sources can be used in our context, neuronavigation, in order to maybe improve tracking and registration throughout the procedure. We're also trying to see if we can, maybe get rid of the tracking system itself and just use a tablet device in certain situations and contexts. And then we're also looking at rather using low-cost ultrasound navigation. And of course, one of the things that I've mentioned is that we really like to bring our technology into the operating room and not just do laboratory experiments. So although we've done, a lot of feasibility tests in the operating room, we want to continue to go into the operating room to get some more quantitative evaluation of our technologies. So just obviously there's a lot of people working on this work, so I just want to thank them and our funding, and of course our clinical collaborators at the Montreal Neuro. So thank you very much.
Thanks a lot, Marta. I think that was really interesting to see how the augmented reality has been playing a role. So I think we can just take, I have one question already here. We can take one from the attendees. If they want to write a question, please feel free to write in the chat, not the chat, Q&A box, so we can take one more question. So I have already one question here from Arman from Germany. So he writes, what is important to teach about uses of AR to medical students and young surgeons? So what do you think is important to teach them about AR?
So I would actually flip that question a little bit and say, I think it's important for them to teach us when it's important to use and what tasks it can be useful for. That being said, I think, and this doesn't just go for AR, I think it goes for, any new technology, but oftentimes, and I didn't mention this in future work, but it's something that we're working on, we present them the AR view, and you're just supposed to think, when you do that, you think, okay, this is the edge of the tumor. And but there's so many error sources impacting the fact that that might actually not be the edge of the tumor. So I think an important thing to to remember is that this isn't accurate to 100%. And so I think one of the things that we're studying now is how can we show that uncertainty information, and how is it going to impact, thinking, okay, the edge might not be here exactly, but it's in this region. And how, again, how's this impacting the user and their decision making?
The know-how of the technology, you mean? So,
yeah. So that can be the AR view, but it can also be like the trajectory of a needle. It's not, on that trajectory exactly, but it's close.
Yeah, thanks a lot. I think we have thanks a lot. It was a very amazing talk. So
Thank you very much.
We have a very short time now. I have requested an extension from Marianne. I haven't heard from her back, but
that's fine.
Okay.
Until they cut us out, maybe.
Hear her. So I think we can take 10 minutes time to discuss, to do a panel discussion, which is supposed to be more over 20 minutes, but I think we can just take 10 minutes time and to really look into more important questions, which could be key to for our research and some nice directions towards what are the next steps. So Duygu, do you have any question for the speakers?
I was just checking that Lily has a question for us.
Yeah.
I think it's still talk specific, but let's go for it. So mobile devices usage in OR, has there been work on underlying interference and radiations from devices impact upon the patient, the users, the electrical tools, e.g. Diagnostic tools in the OR? So it's in the Q&A if you want to read it as well.
Yeah, so I'm not sure if there has been studies. I know we've thought about the security, so we're on like not an external network, Wi-Fi is turned off. I'm sure you could also use, well, I'm not sure you could use Bluetooth, but that's something to consider as well. Considering all the other things in the OR, I think it should be okay. One thing that might impact the LiDAR, for example, might be if you have other infrared tracking, but maybe you wouldn't be using those at the same point in time.
About that, so I think this is also a general question and related to this one as well, and your talk particularly. How will more low-cost hardware solutions influence the field?
I can start with that, but I'm sure other people might want to weigh in. So I actually think that, as I mentioned, I think it's really exciting now because we're getting all these hardware devices. If you think of the cost of a current image-guided surgery system that is, with tracking and everything, $250,000 US and up, we can create much cheaper systems right now, and this is what we're working on, using just the iPad or a cheap tracker and seeing how the accuracy compares on these devices. And I think this, this is really going to start to democratize the care, because of course we have these fancy systems in the operating rooms in some hospitals, but they're not used around the world. So I think we need to, the low-cost devices will definitely allow for, more accurate and easier surgeries throughout the world.
And I think Matthias also had it somewhere in your slides. You had some low-cost solutions for 3D vision. So would you like to add on this as well?
Yeah, sure. I mean, I think most of the work that we are doing is essentially algorithmic based in order to address exactly these issues that come from very expensive instrumentation that is required for robotic surgery or otherwise technology assisted surgery. And once you try to do that, you will find that many of the current algorithms and solutions out there are simply not accurate enough. I mean, for Marta's use case with neurosurgery, the specifications of navigation systems are 1 millimeter, and if you look at image-based tracking solutions, we're quite far away from that. So even nominally, right? I mean, let alone what you achieve then in practice. So I think there is a lot of opportunity to look deep, not only workflow level, that's an entirely different question, but also into the foundational aspects of some of these computer vision algorithms that right now simply cannot give you the accuracy that you are looking for in some of these procedures.
Yeah, so I think I have a follow-up question on that. So, for example, say you have lots of say we always do like simulation studies, and we have mostly based on some retrospective data, right? So, and these studies are published, and we do research on that. So, but do you think that there should be more cohesive approach in a sense that using more prospective data and seeing where is the gap actually, and then this kind of like would open much more, so similar to what Adrian is, so that's really amazing. So would kind of like we had to more synergize our research towards that so that we have more acceptance and reliability of, especially in the AI, right? In the AI sector. So would you like to comment on that? I mean,
I can take a stab if I may. I agree. I very strongly agree, in fact, because part of what my group does, I haven't talked about it, is robotics for orthopedic surgery and so on, right? And it's a lot of surgical autonomy as well. And once you start thinking about that, the way how data is generated is quite different from the way that you can generate data right now, right? If you think about, say, Da Vinci type robotic surgery, yes, if you go into surgery, you can get all the data that you want. But ultimately, the systems that we're operating with right now are not designed for autonomous execution. So if you think about it, you can make your life much easier by designing specialized tools, but you will never get data for that, right? Simply because you can't simply bring it in the operator. Hey, today we're going to use a different tool for you. That's just unethical. So we are embracing that challenge, and the way how we look at it, and I know that other groups are too. Stefanie Speidel, for example, comes to mind into surgical simulation. On trying to do that. So we have open source platforms that allow you to do this for fluoroscopy and X-ray guided surgery. Stefanie Speidel's work complements that, I think, in a way for endoscopic procedures. We now do some stuff for skull-based surgery and bone drilling with haptics feedback and so on. So I think there is the community, I think, is embracing the challenge and is working to it. But then you introduce all sorts of other questions like, training models, generalization, domain shift, what have you.
Yeah. So Edwin, would you like to add? So you have already translated some of your research to the clinic, and we can see that there are really the benefits, right, in doing that. And so, but also you have you talk about some challenges. So, so in your opinion, how should it be more kind of like cohesive, and how can we overcome the challenges, for example, which are existing in current scenario?
So I think there are many challenges, and I've just mentioned a few of them. Typically, the moment that needs guidance during surgeries. So the surgeons don't need guidance all the time, right? They need times where they have times where they know what to do and where they know where to do it, and times where they're searching for something. And typically at the early steps of surgery, which is essentially what I've been showing, the organ is not cut yet, or is just slightly incised, and AR is basically that's the simplest case to register the pre-op model. But then when they start removing something, it becomes much more messy, and it means that we have potentially to adapt the topology of the model, and this is much more tricky. So I would place this as the number one technical challenge. And then of course visualization, etc. There are many out there, and validation.
Yeah, I think Marta, if you would like to comment on that, can we make, for example, with the virtual reality thing, so more like kind of like more accurate visualization in a way that it's more convincing for the clinician to operate and tackle the challenge of what Adrian is talking about, for example, with when you cut it in season and then basically everything is spaced out, right? So there's blood coming out and so on. So lots of challenges there.
It's a tough. Well, I think we can. I think also, again, just to kind of shift it a bit, what's important to understand is, you know, how do we need to make it more realistic? Like for some simulation and VR, maybe we do, but maybe, you know, there's been studies that just show just walking through a procedure, for example, on you know, on a phone that's completely unrealistic might also benefit. So I think we need to figure out, you know, how realistic do things need to be to have a certain amount of benefit, and, you know, or can lower cost and easier solutions, you know, a game on an iPhone also give us some information and also benefit the surgery later if we practice on that, even though it's not as realistic. So I think, you know, there's two aspects. So definitely, I think, you know, and I think there's a space for both, you know, having a very realistic surgical simulator where, you know, even your heart rate is impacted because the visualization is so real, but also having something really cheap and easy that will walk you through some of the possibilities.
I have a question, if I may, for Marta. I think it's about this iPad application you've shown. This is something we've been thinking of, because in our system, we currently require some interactions from the surgeons in the OR, very minimal ones, but still they have to, you know, mark something on the image at some point. And the physical contact with the tablet is a problem because of sterilization for them. And I was wondering if you had this, if you met this difficulty.
So we've done two things. We've used the iPad prior to sterilization. That was early on, and then again we've kind of missed the last year and a half of going into the OR. But what we did was we did test having the iPad in a sterile bag and having the gloves on, and it might, so this is where the registration correction might be a lot harder, but like for picking points, for example, for the hemodynamic analysis, that should be no issue.
I see. Okay, thanks.
So Marta, again to you, there's a question, we have worked out this panel session. So there is AR has been studied now for quite some time in the clinical domain, but it's often not used. So why, you think?
Why? So that is a very good question, because we started this a long time ago, and you know, it's still not in many commercial products. I think it's slowly, BrainLab is using it. Again, I'm not as familiar, I have to say, with internal surgery, but it's slowly making its way. And I think one of the things is that we have to show that there's a benefit. If we can't show that there's a benefit, then, you know, why use AR? And actually, I think Dr. Bertoli, you know, had lots of nice case examples where they were difficult cases and they would have had to convert to open surgery if they didn't have the AR. So I think, you know, as we get more evidence, we'll find it we'll find it more used in clinic. And I also think that low hardware costs will also improve, you know, then we can use it for telesurgery or for, you know, someone guiding telesurgery, I think is a nice application, for example.
Would you say the community is open to the idea? Or how much willing are the surgeons to work with this kind of technology, and what can we make to collaborate with them better? Anyone can.
I'll start, and I don't want to keep taking the floor. I think, okay. Yes. So I have to say, I was really happy to get an email a couple of weeks ago from a surgeon being like, I have a really complicated case. Can you bring the system into the OR? And I was like, oh my God. So for me, that's success. If a surgeon is asking to bring a tool into the OR, that's more success than whether it's made it into surgical products. But I think, you know, you nailed it, saying we need those collaborations, and that will, you know, and then we'll get there.
Matthias and Adrian, do you have any stories that you would like to add? So how is your experience in collaborations?
I completely agree. I mean, surgeons here, so we're part of the same research group, so we're on the same boat, and you know, they exactly like Marta was saying, that sometimes they ask us specifically to bring AR to be there in the operating theater because they have a hard case, and they wouldn't do it with laparoscopy if they didn't have augmented reality. And this is extremely satisfying, of course, in terms of how useful is the research, but also I think it starts to show that there is usefulness in doing it.
Yeah. And Matthias, you said that you are also collaborating with surgeons. So how is your
sure. I mean, I think many of the algorithms that we are developing are a bit for whatever reasons haven't made it to the point where they are ready for clinical deployment just yet. But what I've been finding is that in many of these cases, I think it's some of the clinical collaborators that we have are trailblazers in some of the fields that we care about, but not necessarily in others. So I think, and that's absolutely okay, right? Because our research interests are also primarily in one field and maybe not others as much. So what I've been finding is that identifying these partners who are really interested in taking these ideas and bringing them to the forefront is very fruitful in making progress on some of these. And I think as the first clinical stakeholders have their foot in the door and advocate for the use of this technology, others will follow because they see how it creates an impact and how it is a game changer for some of the procedures and some of the problems that they are facing every day.
Okay, I think we had a question earlier. So Ramkumar was wondering what kind of funding resources are available for this kind of work, but I think we have Northern America and Europe here to represent, so I understand that it's going to differ a lot, but do you have any recommendations? Collaborators that you work with, funding sources?
Yeah, so you have the typical funding sources for research, using the funding agencies. For us, of course, is the European Commission and the national funding agencies. There's also funding from the industry a little bit, and if you want to create a industrialization work, then you may get funding from private funding agencies, I suppose. And I think these are projects which motivate people because they understand it's something that may improve healthcare and people's life eventually. So I think people understand that and they're eager to invest fund into this. Also, the technical challenges are really interesting because you can tackle the industrialization, but also the very fundamental problems which we have, like in my case, this is registration. How can you register different data modalities in spite of defamation and using the right models and measure the precision? So we don't have the answers, the theoretical answers on the shelf for these problems. So you can seek funding to address these fundamental questions, and you can seek funding to industrialize the existing algorithms. So I suppose you can knock on several doors for this funding. Depends on what you want to achieve.
All right. I think in the interest of time, I think we should wrap up the workshop because it's almost around 1 minute remaining for 5, so we are already past 30 minutes more than scheduled. Anyway, it was really nice. All the talks were really amazing, and we learned quite a lot. I hope the attendees did too. Thanks a lot, everyone, for participating and accepting our invitation to give your fantastic talks on what you're doing on computer vision and augmented reality space in surgery. And yeah, we look forward to more interaction in the future. And yes, feel free to email each other and have build some new collaborations. We would be also interested to be part of some new projects. We are also interested. So I think that's really nice that to bring everyone on the floor, and then and also for the attendees who are there, and think you can directly ask our keynote speakers questions. If you have something in your mind, you can directly contact them as well. Do you have anything to say?
Actually, I don't have much to add, and thank you for becoming, part of our workshop. Thanks to our speakers and our attendees, and anyone who's been contributing to the discussion with their questions, and also thanks to Marianne. And I suppose there's a closing ceremony today, so I don't want anyone to miss that, and maybe we should just stop it here, and maybe we'll see you in the next years. Thank you, everyone.
Thank you.
Thank you.
Thanks.
Thank you.